Hi, I'm Dr. James Amos, consulting psychiatrist at the University of Iowa Hospitals and Clinics in Iowa City, Iowa. And once again, this is a dirty dozen, this time on medical psychiatry inpatient units. And the full presentation with annotated slides and video will be available on my blog site, The Practical Psychosomaticist, at jajsamos.wordpress.com, as usual. And as usual, I'll have slides here in front of me as I go through them, so as to stay on track. Slide 3 is about what the medical psychiatry unit is. In terms of definition, it's a combined specialty hospital inpatient unit with the capability of managing patients with complex comorbid psychiatric and medical illness. These patients often would be too disruptive to manage on an open medical unit and or too medically ill to be managed on a general psychiatric unit. There are several types of inpatient integrated programs going from type 1 to type 4. The type 1 has low to high psychiatric with no or low medical acuity management capability, all the way up to type 4 with high psychiatric with medium to high medical acuity management capability. The type 4 is what the University of Iowa Medical Psychiatry inpatient unit is, and it was designed by Dr. Roger Cathall, who is a mover and shaker in the world of integrated medical and psychiatric care of both outpatients and inpatients. The next slide, slide 4, is about the complexity themes that are typically dealt with on a medical psychiatry unit. Complexity in terms of medical and psychiatric issues often entails thinking about which is the major or the minor influence. How do they influence the other? How do they influence each other, rather? Does one cause the other? And thinking about whether or not they share common roots, which is an important way to think about combined medical and psychiatric illness. A quote from Roger Cathall is, "The body and mind function as a unit. To approach treatment of either in isolation is a disservice to those suffering with comorbid conditions and a financial catastrophe to those who have to pay for it." Slide 5 is some information which is probably not current about the number and staffing of medical psychiatry inpatient units in the U.S. As of a couple of years ago, information that I had from Dr. Cathall is that there were a little over 35 of these units in existence, with about 40% of them being in the Midwest and the West, and about 60% of them being in the South and Eastern United States. About half of them were affiliated with academic medical centers. On average, the number of beds was about 18, ranging from 6 to 24. And physician involvement includes internists and or psychiatrists, depending on whether the internist is also boarded in psychiatry. Slide 6 is about the type 4 unit and its operation. At Iowa, the medical psychiatry unit at Iowa has 15 beds with telemetry capability. It's administered by the Department of Medicine, and an acute medical and an acute psychiatric illness is required for admission. There are a couple of models for attending faculty. An internist and a psychiatrist can co-attend, which is how I usually function in my role on our medical psychiatry unit, or a dual board certified physician with training in psychiatry and internal medicine staffs it, and we have that capability here as well. Slide 7 is a slide about the core components. Again, it's administered by general medicine, and in a general medicine setting here at the University of Iowa, it focuses on patients with comorbid and complex medical and psychiatric illness. And we also bear in mind the influence of the healthcare system, challenges, and the psychosocial setting in which the patients arrive in terms of context. There is high acuity and complexity management capability. The Nurses have specialized training in both managing medical problems and supportive psychotherapy. And the unit has medical and psychiatric policies, procedures, and safety features. Slide 8 is about the admission criteria, and in general, they have to have, the patients have to have both active medical and active psychiatric illness. They have to be acute. Delirium is often a major reason for admission to our unit. Self-induced illness, various types, including factitious disorder, can be a reason for admission, and diagnostic dilemmas as well. If there are no comorbid psychiatric and medical surgical illness, that would usually be considered an exclusion criteria for admission. Slide 9 is about how all of the stakeholders communicate with one another on the medical psychiatry unit. And communication is key. The goal in terms of rounds, both work rounds and interdisciplinary rounds, which is held once a week here at Iowa, is to conduct rounds efficiently in order to promote effective patient care and to work on ways to improve that continuously. Case presentations are really more about suggesting ways in terms of our teaching residents how to do presentations, how to organize the content of the history and physical and progress presentations in order to clarify what is to be done, by whom, when, how, where, and why. 10, slide 10 is the presentation framework, and it's really best to hang this on the framework of a story. It has a beginning, middle, and an end. So any presentation will begin with an opening summary statement. The middle will consist of the past medical history and past psychiatric history, medications, family and social history, physical exam, mental status exam, laboratory, and other data. The end of the story basically is a formulation combining a diagnostic formulation which describes what kind of disease the patient has, and then an integrative formulation which describes what kind of patient has the disease. You need both. And the plan consists of the overall goals, with the end in mind, and dealing with the typical internal medicine and psychiatric problem list. Slide 11 is a little more about the team-based model and how psychiatrists and other stakeholders function with each other vis-a-vis the patient and the patient's family. Physicians, especially faculty, are considered leaders who outline general strategies and act as guides. The senior medicine resident organizes the medical interventions and supervises junior residents, and junior residents learn medical procedures, apply internal medicine, evaluation, and management principles in this context. Medical students can function as sub-interns and learn under the supervision of junior and senior residents. Nurses apply nursing medical care and specialized psychiatric nursing communication skills with patients on the unit. Social workers are absolutely essential and work very hard facilitating disposition planning, advanced directives, and family meetings, to name only a few. Physical, occupational, and activities therapists are absolutely critical, along with spiritual services as well, to engage patients in order to mobilize physical, psychological, and spiritual healing. Slide 12 is the last one. It's really an acknowledgement slide to my teacher and mentor, Dr. Roger Cathall, and to give acknowledgments to the nursing staff, who are absolutely critical in the function of the MedPsych unit. And they've given consultations to various hospitals around the country in order to facilitate meeting with multidisciplinary teams to learn about admissions, patient care, challenges, legal issues, discharge planning, administrative and reimbursement issues, and other financial aspects, nursing education, common diagnoses, therapies, and various levels of care toward setting up or towards helping set up MedPsych units at other hospitals, or improving providing care in an integrated way to patients. that's what I have for this particular Dirty Dozen, and I hope you enjoyed it. If you have any questions or comments, please let me know. And if you have suggestions for other topics that might serve as Dirty Dozen presentations, I appreciate hearing them. Thanks very much.